So thank you everyone for joining us. The BC Epilepsy Society is proud to be putting on today's webinar and of course helping people who are living with epilepsy in BC for over 60 years. The webinar today will focus on the use of the ketogenic diet as a treatment option for people with epilepsy, providing a review of the different mechanisms of the ketogenic diet, its clinical efficacy and side effects, and more from the perspective of a pediatric neurologist and a registered dietitian who are both here with us today and who use the ketogenic in their practice. I'd like to start off by just introducing myself. So my name is Christine Jameson. I work with the BC Epilepsy Society as an impact speaker and getting to host amazing things like this. Some of you also may know I was Miss Canada 2019 and Miss BC 2018. I am someone who does live with epilepsy, so I completely understand what people who we help are going through. We have two wonderful panelists joining us today. Dr. Linda Ha is a pediatric neurologist who graduated from medical school at the University of Ottawa and completed her residency in pediatrics from Memorial University and completed 2 fellowships, one in pediatric neurology at the University of British Columbia and one in epilepsy at Yale University. She is currently a pediatric neurologist and the director of the Ketogenic Diet Program at BC Children's Hospital. We also have Lauren Fisher, and she is a registered dietitian who graduated from the University of British Columbia. She's currently the Ketogenic Diet Program dietitian at BC Children's Hospital. So welcome, ladies. So the way today's webinar is going to work is I'm going to pass it off to our 2 panelists who are going to present all the information. If you guys have any questions at any time, if you go to the bottom of your bar, there's a box that says questions, or it says Q&A. So you can just click that and type your question in. I'll be keeping track of all of them, and we're going to be coming back to them at the end of the presentation. Awesome, great. I will pass it off to you, ladies.
Great, so I'll be starting. Thank you, Christine, for the excellent introduction, and also for all that you do for the BC Epilepsy Society and the families here in British Columbia with epilepsy. It's our honor and our privilege to be here today, and Lauren and I can talk about the ketogenic diet all day, but we recognize that we only have about 30 minutes because we wanted to leave a lot of time for discussion and for questions. And so forgive us if we get a bit verbose, but we're both very passionate about dietary therapies. We are just going to go over some of the dietary therapies that you may have heard of that we use for epilepsy therapy. And I will delve in a little bit more into some of its uses and how it works. And then Lauren is going to get into the nitty gritty, really the practical side of things. Okay. If you guys have any questions, please write them down when you think of them, because we're going to be presenting so many exciting things that you'll forget your questions. Okay, all right, so to start, and both of us have conflicts of interest in that we're both involved in studies with the ketogenic diet, and also we're very biased because we're very keto crazy. And so those are the disclosures that you need to know. Our objectives today, we only really have one, and it's to discuss the dietary therapies we use for epilepsy. We will not be touching on subjects that are beyond the scope of epilepsy, although certainly we can try to answer some questions at the end of it, at the end of the webinar if we have time. So why do we even need dietary therapies? Well, this really lovely chart here shows that from the inception of anti-seizure medications in the 1850s, we've had about 18 medications since then. We've had the basic medications and what we call a first generation, second generation, and now we're into our third generation, where these newer drugs, these new designer drugs, may have less side effects, but in the end, has still resulted in 30% of individuals with epilepsy being resistant to medications. And so although we have all these new medications that we've developed, we still have up to a third of individuals with epilepsy who are not well controlled. And so we recognize that we need other possible therapies to offer families with epilepsy. Now, everybody who lives with epilepsy recognizes that epilepsy is not just seizures. You don't even have to be treatment resistant, and treatment resistant means not responding to 2 or more medications. Even if you do respond to medications, epilepsy has a huge impact on an individual and families with epilepsy. We recognize that anti-seizure medications have side effects. We also recognize that the seizures themselves, or the cause of the seizures, can cause difficulties with thinking. We recognize that epilepsy has impact in terms of education, employment, and social consequences. It can result in mood and personality changes. It can really altogether restrict quality of life. And then as most of you have been aware in the media, we've been trying to increase awareness of increased mortality, such as SUDEP and other comorbidities. And so we recognize that that epilepsy itself has a huge impact, and so we need something in our moratorium to fight epilepsy. We're going to be talking about the ketogenic diet. I love this picture because it is a keto meal. Actually, not really, and Lauren will go into that. But this is a meal that I would just love for breakfast. So what is it? The ketogenic diet is a high-fat, low-carbohydrate diet. Okay, it's what we call a non-pharmacologic therapy for treatment-resistant epilepsy. But I want to stress that in no way is it natural. Okay, this is not a diet that is without its possible risks and complications, and I'll go into that a little bit. And is not a diet that that you can just sort of use for epilepsy, just very offhandedly. Okay, and so we'll go a little bit into that. It has been used since the early 1920s, and you'll read in, well, you might not read, but in old medical journals, they talked about, bringing people into the hospital and not giving them anything to eat for 5 days, so fasting them except for just water, and their seizures would get better. And what we recognized was that this state of fasting can also be mimicked by a high-fat diet, which produces ketones. And so even though we've been using it medically since 1920s, if you go back into old papers, it's been used since 500 BC. Okay? We've just modernized it. And so I'm going to hand it over to Lauren to go on from here.
All right. Okay, so I'm going to talk about the different types of ketogenic diets. So this graph really represents the macronutrient distributions of all the different types of ketogenic diets and how it compares to a regular diet, and that's in the top left. And if you do not know what macronutrients are, what I just referred to, here's a little quick review, because I will be referring to these throughout my part of the presentation. So carbohydrates, protein, and fat are our macronutrients. So carbohydrate foods include things like grains, rice, quinoa, breads, pastas, as well as fruits and vegetables. And carbohydrates are ultimately broken down into glucose, which is the fuel in our body. You may have also heard of the term net carbohydrates. That refers to what we actually absorb. The net carbohydrate subtracts the amount of fiber. So for example, if you ate a fruit that had 10 grams of carbs and 6 of those grams were fiber, then we would have 4 grams of net carbs. Protein foods would include things like meat, poultry, seafood, dairy, legumes, tofu, and eggs. And fat is oil, butter, margarine, heavy cream, and nuts. There are many foods that are a combination of more than one food group. So for example, nuts may be high in fat as well as protein. So the classical ketogenic diet is based on a ratio of grams of fat to grams of carbohydrate and protein. So for an example, a 4-to-1 ratio would be 4 grams of fat to every 1 gram of protein and carbs. All food is weighed on a gram scale. And so as a dietitian for the program, I know exactly how many calories, how many grams of fat, how many grams of protein is in a child's prescription. And their diet is modified for their age, their energy and activity level and protein needs. So no diet is the same. We provide their recipes and make changes accordingly. Caregivers are required to do training to make all of the food and provide that according to the child's prescription. Patients are required to measure urine ketones. It is extremely rigid. It requires a lot of commitment and compliance from caregivers as well as the patient. It is definitely the most difficult, but is the most effective. And since everything is so calculated, it makes it easier for us as a team to make changes to optimize seizure control. So if we look at how a classical ketogenic diet compares to a typical diet, at a 4-to-1 ratio, 90% of their calories is coming from fat. And 3 to 5% is coming from carbohydrates, whereas in a typical diet, about 55%, more than half our diet would be things like grains and potatoes and pastas and things like that. So 3 to 5%, maybe as little as 5 to 6 grams of carbs in the entire day. And so for perspective, 1 slice of bread is about 15 grams of carbs. So it's very, very small. And usually it's just a little bit of fruit and vegetables. The recipes need to be followed very closely to ensure it fits in that ratio. And it's very specific. So brand names really matter. So for example, Kraft mayo has carbohydrates versus Hellman mayo. And we tend to start most of our patients on a 4-to-1 diet and our younger patients at 3-to-1. So once they're on a classical keto diet, they have new food groups, and that is butter, oil, and mayonnaise, liquid fat, heavy whipping cream, so 36% milk fat, and protein foods such as like meat, poultry, eggs. And they always have to have vitamins and minerals, because when your diet is 90% fat, we're not getting any of those vitamins and minerals, which we'd usually get from grains or fruits and vegetables. This is an example of what a 4-to-1 ketogenic diet would look like for maybe an older kid or a teenager or a young adult. So this would be about 1/4 of a chicken breast, 1/4 an avocado, a few large tablespoons of mayo, and half a stick of butter, and like a couple leaves of kale. And this has less than 1 gram of net carbs. So really, really restrictive. Higher than a 4-to-1 ratio, it's difficult to meet protein needs in, and it's hard to make it really palatable. But as you can see, still very rigid and strict. This is a picture of a family's actual keto meal. Because fat is so dense in calories, their portions are a lot smaller, which makes it easier for kids to consume everything. But it's a bit of a shock when you're looking at a much bigger volume. So I think this is like some pepperoni or deli meat, and then it's cucumber waves, mayo, and then there's a little glass of whipped cream in the corner that they would drink too. So you have to make it fun and spread it out for really get the kids to buy into it, because it is really intense, but you can make it very palatable. There's also formula available for patients who have enteral nutrition, so if they have G-tubes, or they can also drink it as an oral supplement, like as a meal replacement supplement or have a bit of extra nutrients, because these drinks, although they're 4-to-1 ratio, so 90% fat, they're also fortified with a lot of vitamins and minerals they need. So it can be sometimes a bit easier to incorporate a shake than a couple extra vitamins during the day. These shakes are also, they require a physician or dietitian's consent to get them, so they're not available for the general public to have. So another diet is the MCT oil diet, and MCT stands for medium chain triglycerides. MCT oil is digested faster. It is more readily available to the body, and it yields more ketones, so creates more ketones per gram of fat than our long chain triglycerides. In the MCT oil diet, about 50% of the calories come from MCT oil. The diet, it can use a scale, but a lot of the times they'll use household measurements like a cup or a tablespoon, and a lot of centers will use carbohydrate or protein exchanges. So for example, half an apple may be 1 carbohydrate exchange, and a patient may have up to 5 exchanges per day. So it's still restrictive and it requires compliance, and patients are still encouraged to measure their urine ketones. One thing to note is pure or high grade MCT oil can be a bit costly, as well as MCT oil can be a bit difficult to tolerate. It can cause a little bit of GI upset, of like nausea or vomiting, diarrhea, those uncomfortable things. We use MCT oil in our program, but typically in combination with the classical keto diet. We don't start with it right away. Toronto Sick Kids, though, they use a lot more of the MCT oil diet in their program. So this is the plate representation of the MCT oil diet. So as I said, about 50% of the diet comes from MCT. That extra 23% still comes from other butter, oil, heavy whipping cream, and allows for a lot more carbohydrates because the MCT oil creates more ketones. Greater than 50% MCT can be a bit hard on the gut, so it can cause some of those intolerant symptoms. So modified Atkins or modified keto diet gets its name from the Atkins diet, which became popular in the 90s. It is a low carb, high protein, and high in saturated fat diet, and a lot of people know it for its use in weight loss. Carbohydrates are limited to 20 to 25 grams per day, so much bigger than 5 in our classical keto diet. Does require patients to carb count and label read for accuracy, and about 55 to 65% of their calories are still coming from fat. It is definitely less restrictive, but it yields a little less ketones. So this would be an example of a modified keto plate. It's really great for more suitable for adults or older and independent teens because it's quite accommodating for eating out. Someone may be able to order a dish without the bread or potatoes and have it fit within that modified diet. And they may be able to purchase certain packaged foods like bars or snacks. And so about 50% of patients on a modified keto diet may have a 30 to 50% decrease in seizures. So already touched on these things. So yes, it's definitely more accommodating, less restrictive. So our low glycemic index diet is based on the glycemic index. So glycemic index refers to a food's ability to raise blood glucose levels. Foods that are high on the glycemic index, so this high red line, includes things like white bread or sweets. These foods provide a rapid increase of glucose into the blood, like shown on this graph. Foods that are low in the glycemic index include things that are high in fiber, such as whole grains, oatmeal, vegetables. They have a slow and prolonged release of glucose into the blood, so that's that green line there. So those foods are considered low in glycemic index. So the low glycemic index is a less restrictive diet. It's still high in fat and has carb restrictions, and the carbohydrates that they do consume must have a low glycemic index. So those really high fiber grains and vegetables and some fruits as well. They actually don't need to measure your ketones on this diet, as this diet generally does not promote ketosis. And about 30% of patients will have a 90% reduction in seizures, and 20% will have a 50% reduction in seizures. The Children's Hospital in Alberta uses this therapy often. It is reported that is quite effective in patients with Angelman syndrome. So, so this is an example of, so as we can see, the plate still shows high fat, but much more carbs than some of our other diets. And the meal, that dish there is a cauliflower and cheddar hash done in a waffle iron to get that crispy hash brown. So I feel like that's something I could definitely eat. So another thing, it's not just food that contains carbohydrates, everything contains carbohydrates. And this is something that we teach our families to be really aware of once their child is on the ketogenic diet. So medications like liquid and chewable medications can have carbs or sweeteners that can impact their ketosis and their seizure control. All of their vitamins and minerals may have carbohydrates, so we prescribe them certain brands and certain formulations to make sure that although they need these vitamins and minerals, it doesn't impact their seizure control. And everything that may be related to like personal hygiene, so anything that sits on the skin for a long time that may be absorbed, like our sunscreens, lotions, and soap, can actually absorb carbohydrates through the skin, and that may impact their ketones and seizure control. So this is more than just a diet, it's definitely a big lifestyle change and adjustment for families. All right, I'll hand it back to Dr. Ha.
Okay. Sorry, I love hearing Lauren talk, so I got a little bit distracted. But let me restart it on my end. Okay, so Lauren talked about the exciting part, which is the food part, but I'm going to go into a little bit about how the diet works and how it started and how one does the ketogenic diet. So first of all, we don't know how the ketogenic diet works. And sometimes that makes people a little bit uncomfortable, but in medicine, we don't always know exactly how things work, although we do have a good idea. In terms of how the ketogenic diet works, you really need to go back. And some of you may be cringing at this diagram because it reminds you a heck of a lot of biology in high school. But in order to understand the ketogenic diet, you kind of need to understand how the regular diet metabolism works. And so if you look on the picture on the left, you see that the pancreas, so when you have low glucose, if you start at the top, that the pancreas actually releases something called glucagon, which is a hormone that actually increases glucose levels. When you have low glucose, your muscle breaks down, so your protein goes to amino acids, and that produces glucose. Your red blood cells and your white blood cell can actually produce something called lactate. And so people would recognize that from, when they're exercising a lot, the lactic acidosis, and that actually gets converted to glucose. And so there's a lot of ways that you can actually make glucose, and almost everything in the body will preferentially use glucose as an energy source. Now, ketones are produced either in times when you don't have any food coming in, so when you're fasting, or if you have a high fat diet. You can see there on the right of that diagram that free fatty acids or fatty acids get converted into ketones. And the brain actually loves ketones. The brain really works really well on ketones. However, with high levels of glucose, it typically will go for the glucose because it's an easier pathway. And so what we're aiming for is to produce ketones. So ketones are the anti-seizure medication of the ketogenic diet, or at least the main anti-seizure medication of the diet. That there are a few other ways that it works. And so this very complicated diagram, in order to summarize it, just basically shows that there are at least 5 different ways the ketogenic diet works, which is why, we feel it actually works so well, why it's such a strong therapy for epilepsy, and also why it doesn't really choose certain types of epilepsy in terms of the way it works. It can work on all types of epilepsies. Okay. So when do we use dietary therapies for epilepsy? When someone has failed 2 anti-seizure medications or more is when we would offer the ketogenic diet. We also offer it in certain conditions that people are born with. One is one called glucose transporter 1 deficiency, which is quite rare. Another one is an energy metabolism issue, pyruvate dehydrogenase deficiency. And actually, this is the therapy for that. And even if they don't have epilepsy, we would use it for that. Other conditions where it may work, and many of you may have heard of this, it's the ketogenic diet has been receiving a lot of hot press in the last decade or so. Where it's starting to be used is cancer and brain tumors, in Alzheimer's disease and other dementias, in traumatic brain injury, in autism, and also in Parkinson's disease. And this really speaks to the different mechanisms in terms of how it works. Although we do know that it does calm down the brain's extra excitability, we also know that it has a neuroprotective effect, and it also helps improve, people's mental status or people's level of alertness. And so, in addition to that, we also know that there is an anti-inflammatory effect, and so that's why people, are using it in things like cancer and brain tumors. And so, people are using it in different conditions, not only epilepsy, and you probably would have heard of it through that as well. Does it work? Well, 50 years ago, I would have said, we think it does, but now with confidence, I can say it definitely does. And we've had multiple studies, even the highest grade of study, which is a randomized control trial, they all show that it works. Okay. The bonus that we've been looking at in these studies is that the ketogenic diet also shows that there's an improvement in terms of the level of alertness and people's ability to think, what we would call an encephalopathy. And so that's been something that it's shown. It also has been shown to improve sleep. Is it cost effective? So when I say that, we know that the ketogenic diet can be expensive. Some of these foods cost more. The formulas, are costly. Also, it's very resource intensive. So I'm going to go into how we start the ketogenic diet, but you'll see that it takes a lot of dietitian time. And, our dietitian is actually probably our most precious resource. But when you take into account all of the extra expenses, it does show that it is cost effective. There was a study done actually here in Canada that looked at the costs that people incurred with difficult to control epilepsy before the ketogenic diet and compared to after the ketogenic diet, including the cost of starting the ketogenic diet. And it showed that, but hands down, there was a significant decrease in healthcare costs. And so we know it works and we know it's cost effective. In terms of when you cannot use a ketogenic diet, there's actually multiple genetic conditions and certain medications where you cannot use the ketogenic diet. And so it's important that the ketogenic diet be started after assessment by the medical team. Other contraindications, as I mentioned, there's certain medications which cannot be used with the ketogenic diet without risk of harm. Other times we discourage the use is if there's a risk of aspiration, so swallowing some of the foods into the lungs because of the high fat, it can cause a terrible pneumonia. If someone already has a history of high cholesterol or high lipids, or a history of kidney stones, I'm going to go into the side effects, shortly. We do look at that with caution because it can really exacerbate that tendency. And so, that's something that we really look at and balance risks and benefits of being on the diet. The last one I put in my other hat is epilepsy surgery. And so I do have to put a plug in that if someone is a really good surgical candidate and that we can offer, a good chance of seizure reduction or seizure freedom with surgery, we usually tend to recommend going the route of surgery instead. And so while it's not a contraindication, it is something that we would counsel on. And there's no harm in going on the diet than going to surgery and considering both paths. I'm going to go a bit into the side effects of the ketogenic diet. And I want you to know that these are potential side effects. Not everybody gets these, okay? And so I don't want it to scare you off the ketogenic diet, but it is something we do see frequently. When we start the ketogenic diet, you have to remember that if you go back to Lauren's comparison of the regular North American diet, that we're not eating 90% or even 60% fat. And so most of our diet comes from carbohydrates. And so our bodies are used to running on carbohydrates as a fuel. When an individual converts from a carbohydrate metabolism, or using carbohydrates as fuel, to fat, there are some difficulties, I should say. Many people call it the keto flu, but children and adults will get quite fatigued. They'll get nauseated. Vomiting may occur, especially if it's also compounded by constipation. Low blood sugars don't tend to be common, although we can see that, and that's just the body getting used to getting into the fat metabolism. So we do, watch out for low blood sugars during the time of conversion, and also dehydration. I don't know how many of you guys have ever had a day where you've really gone a bit crazy on high-fat diet, like you ate McDonald's. Not that I'm dissing McDonald's at all, but 3 times a day, you feel really awful. You feel, your stomach feels really full, you feel bloated, you feel a bit nauseated, you feel very thirsty. Well, that's how it is for, up to 3 days. But then once an individual converts from the carbohydrate metabolism to the fat metabolism, they do much better. And like I said, it's not everybody, but it is the majority. And we do warn people about this, ahead of time. But once they're on the diet, this is not an issue. Okay. I'm going to go a bit into the long-term side effects of what we see and why we do the things we do when people are on the diet. And so the biggest thing is really gastrointestinal or gut issues. Okay, so constipation tends to be quite common, and that's just because if you look at, how much carbohydrate and protein people are allowed to have, when you take into account medications and such, there isn't a whole lot left for fiber or vegetables. And so constipation does tend to be more common, especially since fat tends to slow down the motility. Some people get diarrhea, especially if they're on higher MCT oil or something. High lipids and high cholesterol does occur on the diet quite commonly. Sometimes the body will correct itself and that'll autocorrect on its own, or sometimes we need to take measures to bring it down. Inflammation of the pancreas can actually happen as well. It's very rare, but it's something that we really watch out for because that can be very dangerous. Other potential side effects, so nutritional. As Lauren said, we're not offering a whole lot of vitamins and minerals, and so vitamin and mineral deficiency used to be very common. We do check vitamin levels and mineral levels quite commonly now at the beginning, and then every 3 months initially, and then we supplement really quite aggressively in order to avoid deficiencies. Carnitine is a protein that shuttles fat across the membrane, and so you do need that, and sometimes on the ketogenic diet that can be depleted, and so we measure that. Previously, growth restriction, and you'll read about that when you read about the ketogenic diet. We do aim to give enough protein for children to grow in terms of along their percentile, but sometimes, after people come off the diet, you will see them doing some catch-up growth, so to speak. We do not aim to lose weight. This is not a weight loss measure, and surprisingly, even though your individuals are on a high-fat diet, they don't actually gain weight, and that's really Lauren's job, is to ensure that the proper amount of calories is met. In terms of the kidneys, the ketones tend to cause a bit of an acidosis in the blood, and most people aren't affected by this whatsoever, but that does tend to increase the risk of kidney stones. And so people who are on the ketogenic diet often are on a supplement to try to decrease that. Longer term side effects is really the things that we worry about is really bone density. People with treatment resistant epilepsy do have a tendency for decreased bone density. And that's due to many factors. Some of the factors is long-term medication use. Other factors is decreased activity. And other factors are genetic factors, but the ketogenic diet definitely has an impact on bone health. And so we supplement very aggressively with calcium and vitamin D, but we do have to, weigh the benefits of the diet with the risk of things like fractures in the future. Low white blood cells is something that we see, although rarely does it actually, make a clinical impact in that people are immunocompromised or they have troubles in fighting infection. And then in the past, we used to see more cardiomyopathy, but that's really rarely seen now. And it's proposed that it could have been due to a micronutrient called selenium, but we rarely see that now. How is it done? Well, initially there's an assessment by the ketogenic diet team. That's myself, who is a ketogenic diet physician, or one of my ketogenic diet colleagues. We have Lauren, who is a ketogenic dietitian. And then we have excellent nurse clinicians who are experts in this field and who are also an integral part of the team. The things we ask is, are there medical contraindications? Are there medical reasons why someone can't be on the diet? Will the family be compliant? Is this a good fit for the family at that time? What are the medications we need to make? And as Lauren mentioned, there are no suspensions allowed. And what's the urgency that we start? And although everyone is urgent to us, there are certain conditions or certain situations where we have to start it immediately. And there's certain situations where, they can wait a few weeks or even a few months if that's what the family prefers. The way we started is families will undergo 3 to 5 days of education in the kitchen with Lauren and our nurse clinician. Initially, they don't eat for 6 to 8 hours at nighttime, and then we do the blood work in the morning to see what the baseline is in terms of minerals and vitamins and fats and things like that. And then we gradually increase the ratio over 3 to 4 days if it's a classic ketogenic diet. The parents are instructed on the preparation of meals, so measurements, how to calculate, the different grams of everything, and then also how to monitor ketones. The ketones are sort of our drug levels in that it tells us how effective the ketogenic diet is in an individual. Initially, we look at blood sugars to make sure people aren't going low, but that's only in the first 2 or 3 days. The ketones are really what are measured on a long-term basis. The best by far in terms of the gold standard is blood, and that's what we measure is beta hydroxybutyrate, but it's very, most families can't go to the hospital on a regular basis to get that done. There are ketone meters, and on the bottom right, you'll see an example of the ketone meter. Some of those are a bit fraught with reliability, but they do tend to be accurate. They are extremely expensive though, not the actual ketone meter, but the strips can be very expensive. And so it doesn't really make it so accessible for people. We typically use urine ketones, and you'll see them on the top of the picture there. And that's where we actually use a dipstick to check the urine ketones. And those are probably not the best, but they are the most practical. And sometimes what we'll do is we'll try to correlate them with the blood ketones, and then they do tend to be reliable. Breath ketones are also an option, although not very accurate, and we don't use that very much at all. And so how long do we usually trial it? We ask for 3 months because 3 months is what we need in order to get good ketosis and to really adjust the calories and the nutrients and the ratio accordingly. And so we ask for a commitment of 3 months no matter what. And then how long do we continue it? Well, we usually continue it for 1 to 2 years. We follow up at 3 months, and usually every 3 to 6 months thereafter. We do routine blood work, weight, physical examinations. And after 1 or 2 years, we would offer for individuals to come off. Sometimes people can't come off because their seizures recur, and so we do have some individuals that have been on it much longer. But those individuals, of course, we have to risk the risks and the benefits of being on it more long term. The majority of individuals will actually continue to have seizure improvement even off the diet, and so that's when I talk about that neuroprotective effect of the ketogenic diet. And in terms of long-term side effects, everyone would think that they would have, arteriosclerosis, and they would be having, heart attacks and strokes. But actually, long-term studies do not show that there's an increased risk for cardiovascular disease. And so, and that's probably what we see in that the liver or the metabolism does tend to even out. We have seen that the growth does slow, although improves once off the diet. Kidney stones and the bones are something that we worry about in terms of long term. But although this sounds very difficult, when they did a survey of everyone who who was on the ketogenic diet, 96% of them would answer that they would recommend the diet to others, but only after trying medications, because as one of our wonderful families has said, excuse my language, it sucks, but it works. So it's something that people who have been on it, although it is quite difficult, they do feel that it is worth it once they're on it. Okay, and so that's the end of our presentation. I think we were good for time.
Yeah, you guys were great. Thank you. So we have a lot of really great questions here, some for Linda, some for Lauren, and then some that I can answer from the BC Epilepsy Society. So we'll start with this one for you guys. And it's, can the ketogenic diet be used with other treatments such as medications, VNS, etc.?
I can answer that. Definitely. And in fact, it almost always is used with other therapies. If you think of, one of the criteria for starting the diet, it's after failing 2 medications. And so typically when people start the diet, they are often on one medication to, actually the most common thing we see is actually 2 or 3 medications. If the diet works, we really get down to peeling off those medications. The vagal nerve stimulator has also been shown that, they can be additive in terms of, the effect. And so, the ketogenic diet is not something we take off, but, something that we use together.
Perfect. So we had someone ask if they can get a copy of the PowerPoint slides after the presentation. So if anyone would like a copy, if you just simply send us an email, we'll make sure that we get you all the information that you need. And if you have any further questions, we can answer those at that time as well.
And Christine, I think this is recorded, isn't it?
So if you would like a recording of it, we will have that available as well. So we did have a question over here. This is geared towards children. Is the information similar for adults?
I can answer that too. Sorry, Lauren, you can pop in anytime you like. Yes, so we did try to make it applicable to both children and adults. Right now, the Vancouver General Hospital does not have its own ketogenic diet program, although it's something that we're looking into, is a provincial pediatric adult ketogenic diet program. We've been speaking to our adult colleagues and both at VGH as well as Fraser Health about starting an adult ketogenic diet program. So there will be a program, and I do feel that there will be, but the information would apply to both adults and children.
Awesome. So we have another question here. What is your preferred method of measuring ketosis? I believe after adapting to the ketogenic diet, ACAC is not excreted in the urine as much, which leaves us with the serum BHB levels and breath acetone. So I think you talked about this a little bit, but would you be able to elaborate?
Well, what's my preferred level? I mean, our preferred method. I think preference is about convenience as well as accuracy. And so that's a fine balance. I think if someone can afford a ketone meter and they don't mind being pricked, once or twice a day, or pricking the kids once or twice a day, that's probably preferred in terms of accuracy. Sending someone to get blood work is not an option for us, just because, I don't think that's practical for an individual in terms of the quality of life, but we do it when we need to. And so urine ketones tend to be a really good surrogate marker, and we have been using them quite often. They're non-invasive. And they're easy to do. And so people can check them twice a day, even 3 times a day, without, causing too much discomfort, without causing any discomfort to the child or to the adult. And so that's probably preferred in terms of, for patients. The breathalyzers, I think they're great. I think they're fine. They're just hard to get, and they're prone to malfunction. And so then you end up getting blood work and, or, switching to a ketone meter. And so, we teach the urine ketones when we teach the ketogenic diet. But if someone wants to do, a ketone meter, we can support them in that way for sure. I know that wasn't an exact answer, but preference is just that.
No, that was very good. Is there a difference in the efficacy and reduction in seizures with the classical ketogenic diet and the other variations?
Yeah, for sure. Yeah, the classic ketogenic diet is by far the most effective. 20 to 30% will become seizure-free, and up to 2/3 will have a greater than 50% reduction in seizures. And so the classical ketogenic diet, which is a 3-to-1 or the 4-to-1 ratio, is definitely the most efficacious. The other ones have anywhere from a 30 to 40% of 50% reduction. Okay, so only 1/3 will have a 50% reduction. But if you look at other medications, the ones that go to market, many of them have the same efficacy. So it's kind of like trying another medication, so to speak. But the reason we use them is because they are more flexible, and they are, more palatable, and they are a little bit easier because, Lauren, you can speak for this, but we find it really almost impossible for adolescents or adults to follow the classical ketogenic diet.
I think what's really tough about the classical ketogenic diet too for adults or older teens, especially if they're more active, have a higher protein requirements, and there's just such little carbohydrates. It just makes it not very palatable, and it's not very accommodating to someone that has like going out with friends or that social aspect as well. Like you couldn't go out to eat at a restaurant or have kind of an spontaneous meal, so that makes it really tough as well to do a classical like in our more spontaneous lifestyles.
Sometimes we can, for children and adults who are G-tube fed, we would always go with a classical diet in terms of the formula. So if someone is exclusively formula fed, through a tube, the classical diet would be used.
Sorry, I forgot to unmute myself there for a second. So Lauren, you had mentioned that fruits and vegetables are high in carbs. Are there some fruits and vegetables that are better or worse for people to eat while they're on a ketogenic diet?
Yeah, there's definitely not a better or worse while on keto. I think what's the most important part about our fruits and vegetables is the fiber content. So like I said, that part is not absorbed. So the biggest difference between fruits and vegetables is the amount of fiber they have. So something like celery is very high in fiber, so you're not digesting, so you get a lot bigger volume, but the net carbohydrate is the part that's absorbed and what we're looking at. So if I'm making a recipe or recommendation, I'll keep the net carb the same. So they might have like 1 gram of net carb, and that volume will change depending on how much fiber is in a fruit and vegetable. So if someone has a higher appetite, something that's really high in fiber like celery or lettuce or carrots, something like that might be better because it's more feeling because it's higher in fiber. But then if someone's not feeling well, has a smaller appetite and has a hard time finishing meals, and something that's lower in fiber and has a bit more of that absorbable carbohydrates like berries or apples is something easier too. So pretty much all fruits and vegetables fit. I would say the hardest ones are like potatoes and bananas because they're really starchy and they don't have a lot of fiber. Those ones typically don't really fit, but everything else pretty much works. So no good or bad.
Awesome. And a really interesting question here is do we expect to see changes going into the future with this diet, and where do you see that might be advancements within the ketogenic diet?
I can
I love that question.
I think what's really exciting from the food part of it is I know that it's been around more in the media as like weight loss, but it's brought a lot of really neat products on the market. Like I saw a keto pizza crust in my local grocery store, and I was looking at the labels and I was like, oh, this is actually like one of my patients could actually use this. This is super cool, which before pizza was kind of off the menu. So I think that's really exciting, is there's just definitely a bigger market. So companies are getting more and more innovative with things that actually fit in a medical keto diet. So that's exciting.
On the medical side, we've been talking about getting the ketogenic diet in a pill. So once we can figure out the mechanism, we can make it a lot more available to many, many more individuals. And so I do think that we will get there. We'll be able to offer it, in just a pill where people don't have to change their whole diet. The other thing about it is, we're actually looking at this right now at BC Children's and in conjunction with Calgary Children's. But we know that the ketogenic diet changes the microbiome, so the gut flora. And I think that's been also a very hot topic in the last 10 years because we know, essentially you are what you eat. And so we know that the bacteria, the organisms in our gut can be changed by the ketogenic diet. And so hopefully by studying what those changes are what are good organisms and bad organisms inside the tummy, we can look at another way that we can offer the ketogenic diet, in a pill, so to speak, or through other ways.
That is amazing to hear all the advancements that are happening. So if someone is allergic to, so can the diet be done if someone is allergic to dairy? As there, in the examples you gave, Lauren, there was a lot of cream involved. We talked about whipped cream, or someone who's vegan. As we also talked about egg-based mayos and that sort of thing. So is it possible for someone who has dietary restrictions to find a balance in the keto diet?
Yeah, I think a classical ketogenic diet without dairy would be really tough because a lot of just because it's so concentrated in fat, and the heavy whipping cream just makes it really easy. If you can drink that, like water it down and make it into like a glass of milk, it makes the meals a lot more palatable and just kind of easy to take down. So I have a lot of families that rely on heavy whipping creams, like one of their main ones, for the classical diet. So I think if it was a true cow's milk protein allergy, classical would be hard. Usually if it's lactose intolerance, that can be accommodated into classical, because butter, mayo, and heavy whipping cream, it doesn't actually have that much lactose. Or you could take something like Lactaid, like a lactose enzyme. So it'd just be exploring those options. It's not impossible, but it would be challenging. And I think vegan, like a completely vegan diet out of the classical would, I don't know if it would work at a 4-to-1 ratio. I haven't tried doing the math yet, but the beans and legumes that are really a staple of protein in a vegan diet are also quite high in carbohydrates. So that one would be tricky. It might be something easier, like a low glycemic index or the modified, but classical would be really tough.
Great. So does the diet have any negative interactions with seizure medications that we know of?
I can answer that. No, it does not. It doesn't. It's an interesting therapy in that it doesn't really affect the levels of other medications. There are some medications, though, that can potentiate some of the side effects, and so some of the medications that already predispose to kidney stones, like topiramate or zonisamide or acetazolamide, those we just watch with caution, and we supplement with higher, potassium citrate, which is what we use for, lowering the acidity of the urine. And then there's other medications such as valproic acid, where we have to watch carnitine levels because they can also deplete those a little bit. But and then other medications sometimes, rarely can some people get a little bit more sleepy once they start the diet, but no, it doesn't actually affect other drug levels or affect the way that they work. It's a good question.
So on the same sort of note, are there, we talked about medical contradictions that would mean someone can't be on the ketogenic diet. Could you give an example of what that would be?
Yeah, so the one that we most commonly see is probably carnitine deficiency. And it's when someone actually is missing that protein that shuttles fat across the membrane. And so if that happens, it can be quite disastrous. And there's some other genetic conditions that we see that, are quite rare, but should be ruled out.
Awesome. So you did already answer this one a little bit in your slides and in your presentation, but how long would someone expect to be on the ketogenic diet for?
So we ask for a 3-month commitment, and that 3 months initially is, it allows us to adjust calories, ratios, food preferences, and make sure that we really, dialed it in, so to speak, before giving up on it. If someone responds to it, then typically we would use it for at least 1 to 2 years. That's a decision that we make with the families as we go along. We're definitely not prescriptive about that, and it's something that we revisit at each visit and talk about. But many conditions, what it's used for, we would go up to 2 years, and then consider taking them off. If they do get worse coming off, sometimes we may go back on it. And I think the longest one we ever had was probably 14 years, but that's really, really rare. And that individual made a conscious choice between, seizures, and the bone issues and some of the protein issues and things like that. But that's very rare.
So if someone is experiencing digestive issues from eating a lot of, keto is very high in fat, is there a keto-friendly way to help with sort of gut issues? I know it's a very large topic, but just skim the top of it.
Lauren, you made me go on first. It depends what the digestive issues are, actually, because you know, the diet being a diet, you know, its primary side effects tend to be, you know, in the gut, and so, you know, knowing what we know about, you know, there being a slowed motility, you know, in terms of things moving. I don't want to get too graphic here, but you know, constipation tends to be quite common, and so if it's constipation, we would work on that. If it tends to be, you know, more of a bloating or a gasiness, then we would try to work on that. If it tends to be diarrhea, then we, sorry, doesn't sign up for a for a GI talk, but then we would work on that. I don't know, Lauren, do you?
Yeah, for food, we wouldn't really make any foods, like especially if it was something that was really working. There's not a lot of wiggle room or a lot of changes to make, but there's just maybe spacing out the meals, promoting like a bit more activity can always help. But with the diet being so high in fat, there's not a lot of wiggle room to maneuver it. I've had families like want to be on probiotics, and I don't know if that's helped. It's hard to know.
Yeah, probiotics we don't actually encourage, because probiotics are not, I'm going totally off topic here and I apologize. Lauren, you
open that door.
But you know, probiotics are not, you know, are not regulated in any way, so you actually don't know what's in the probiotic. And if you did know what was in it, you don't know what the levels are that are in there, and you don't know which are the good bacteria and which are the bad bacteria. You know, the microbiome of an individual changes depending on their age, depending on their diet, depending on where they live, what medications they're on, and so we don't actually know, you know, what the good bacteria is, so to speak. And so it's always hard for us to make those recommendations.
Great. That was a very good answer to a very difficult question. So a really good question here. We have a lot of people within our epilepsy circle here who are more independent. So for those who are more independent, does the ketogenic diet have a negative impact on people who take part in high output endurance sports like cycling or running and that sort of thing?
I can answer that, Lauren, and then expand on that. Yeah, undoubtedly, and I will. Are we done? Oh, we're not done? Okay. Undoubtedly, when someone starts a ketogenic diet, there will be changes in energy. And that's just because, you know, the body needs time to get into the metabolism. With the help, the reason, you know, we really mandate that a dietitian follows an individual is because a dietitian is able to change those caloric needs and the energy needs, and that is done exquisitely and very independently. There are definitely, you know, long distance, you know, endurance athletes who are on the ketogenic diet, very high performance athletes who are the ketogenic diet, but you know, their diet is a science. I'm sure they have a whole team working on it. Yeah, you know, if followed by a dietitian who has good expertise, you know, one should be able to do all of the activities that normally one does, even if it's a high performance competitive, you know, competitive sport. Lauren, do you want to?
Yeah, I think I've worked with a few kind of teenage boys that were highly active and played competitive sports and have done a ton of activity, and it was just required a lot of really close communication and monitoring to make sure they were able to do that, and providing them enough energy to do all of those things still. So haven't seen any negative issues once they're kind of stable and being followed.
Great. So the next question is a little bit longer. So Dr. Linda, you stated that the presence of ketones is what has the anti-seizure effects, but there was also a statement that the low glycemic diet resulted in reduced seizures. Have you been finding with dietary interventions that are lowering overall glucose intake without increasing fat or modifying vegetable fiber intake beneficial for patients as well?
Excellent question. And I feel like Elizabeth Teal planted you. Elizabeth Teal is the epileptologist, actually, who initially came up with the low glycemic diet. And what she noted with one of her colleagues is that, that maybe you don't need the ketones. Maybe what you need is a lower level of glucose or a more stable level of glucose. And undoubtedly, I do feel that's one of the mechanisms. And so I did contradict myself, and I love that you caught that. That's awesome. And you're a really good listener. But yeah, so we use ketones as sort of the drug level, but I don't think that that's the only mechanism. In fact, you know, one of the one of the more common mechanisms that people study in animal studies and in humans as well is studying, you know, that lowered level of glucose, which people on the ketogenic diet definitely have. I can tell you if someone's got good ketones by looking at their glucose levels because they run lower. And so that's definitely one of the mechanisms. We also know that another mechanism is fatty acids. So we know that it changes the membrane, and that's not a ketone thing. That's actually a ketogenic diet thing. And also there's changes in terms of some of the brain chemicals, a lot of the ones that you might recognize for mood. So serotonin, dopamine, what we call monoamines, those are also changed. And I think that's what's responsible for that level of alertness, or that, you know, that people feel a lot more awake when they're on the diet. So you're right, you know, although I see the ketones are sort of the mainstay of the diet, it's really not the only one. And the low glycemic index diet specifically works on that lower level of glucose, or that sort of even state of ATP, the energy substrate. Interestingly, they sometimes do have ketones. And if you look at, you know, the fat content, it is higher than one normally would, but in conjunction with the lower glucose levels, you know, it does tend to work.
Great. So this question, if someone wasn't taking Chinese herbs, is there any sort of contradiction with that and the diet?
Like just Chinese herbs in general?
Yes.
Yeah, okay. Well, like I said, some supplements, a lot of supplements actually, they might have other additives. So if you're taking something in a pill formation, it may have any kind of additive that may contain carbohydrates, and that would affect their ketone level if we weren't aware of it. Stuff like any kind of dried herb, like usually they can use in cooking, and that won't affect if it's like a dry herb on its own, usually won't affect ketones. If it's something like a herbal tea, as long as it doesn't have any, they don't affect ketones from a general point of view.
Great. I am going to mispronounce this word. Are exogenous ketones ever used?
Exogenous ketones?
Thank you. Yes.
No. So you might see in like a health food store or something like that, they might have like ketones on a bottle, and you're like, wow, that looks interesting. But we don't use those because it doesn't actually, like, we digest them and it doesn't actually get to the brain. It's also one of those other products, it's not regulated. And I've had reports from dietitians and other centers where their patients have used them, and they might have a little increase in ketones after, but then overall their ketones level drops after they use them. So it's not something, it's such a new product, we don't know much about, so it's not something we use at all. I don't know if you have anything else to add about that one. Okay.
Perfect. Well, that is all the questions that we have. I'm just going to. Or not. Okay. So that's, hold on. Any, no. So that is all the questions that we have, and I want to start by thanking all the attendees who came out today. We love having you here, and we would love to know what other webinars you want to see and what else we can do. So please feel free to contact us by email at info@bcepilepsy.com or by any of our social media channels. And a huge thank you to Lauren and Linda. So we'll be sharing out this webinar and we'll have copies of it. If you'd like a copy, simply send us an email. That would be great. Any last words, Lauren and Linda?
No, but thank you for coming and giving us a whole hour of your very precious.
Thanks for having us.
Perfect. Awesome. I'm going to end this webinar here, and I just want to send out one more big thank you to everyone. Have a great night and a great rest of your week. Bye, everyone.